Welcome everyone, and thank you for joining us for the first session in the Doula and Perinatal Community Health Worker and Medicaid Virtual Learning Series. My name is Dr. Jennifer Moore, and I'm the Founding Executive Director at the Institute for Medicaid Innovation. I'd like to begin by thanking our partner, Every Mother Counts, as well as Community Health Acceleration Partnership, or CHAP, for their commitment as funders to advancing important perinatal health topics in the Medicaid population. Through their generous and ongoing support, we're able to offer this free national learning series. The Institute for Medicaid Innovation is a 501c3 nonprofit, nonpartisan research and policy organization charged with producing unbiased and objective resources that informs Medicaid policy to improve the lives of Medicaid enrollees, caregivers, families, and communities. We develop, implement, and disseminate innovative and evidence-based models of care that promote quality, value, and equity. IMI's 4 strategic priorities include access, coverage, and outcomes, community and equity, data and quality, and the sustainability of the Medicaid program and IMI as an organization. We accomplish our mission and strategic goals by leading work in several key areas, such as women and gender health and disparities in equity, through a range of activities, including leading national learning collaboratives and hosting convening meetings with multiple Medicaid stakeholders, to quantitative and qualitative research studies that are published in peer-reviewed journals. And although we love our data and data analysis at IMI, we have a saying that remains core to who we are. It's not the statistics that make Medicaid real, it's when you love one of the numbers. As a former Medicaid enrollee of 8 years as a child and 5 years as an adult, I know firsthand how important the program is for individuals, families, and communities. It is a critical safety net program. We are thrilled to welcome 1,000 registered participants. Yes, you heard that right, 1,000 from 48 states and the District of Columbia for this learning series. We have representatives from Medicaid health plans, state and federal Medicaid agencies, and provider and community-based organizations, including doulas and perinatal community health workers, the focus of this series. To help get us oriented to the learning series, I'm going to hand it off to my colleague, Yanti Wheeler.
Thank you, Dr. Moore, and good afternoon and welcome to our participants. I'm going to review some details. This series includes 8 monthly 1-hour Zoom sessions. Topics will address relevant policy issues with pre-session materials, supplemental resources, and invited subject matter experts. Sessions are recorded and will be archived on the IMI website. All attendees are automatically muted. The chat feature is disabled. However, we have reserved time at the end of the session for you to ask questions for our guest speakers. To participate in the discussion with the speakers, please use the Q&A feature to submit questions and comments. You can submit questions throughout the session. The questions will be consolidated and shared by the moderator during the Q&A portion of the panel. You will receive an email message with a link to complete a short 3-minute feedback survey. As a reminder, completion of the survey is required as part of your participation in the learning series. We actively review and incorporate your feedback into future sessions. We look forward to hearing your thoughts. Finally, all materials will be available to you on the IMI website about 2 weeks after the session. Today's learning objectives are to identify the definitions and scope of work of community-based doulas and perinatal community health workers, the evidence supporting these models as cost-effective strategies to improve outcomes, member experience, and birth equity, and the important related public health policies. Back to you, Jennifer.
Great. Thank you, Yanti. And as a reminder, we invite all attendees to submit your questions at any time throughout the session using the Q&A feature. Before I hand it over to our partner in this learning series, Nan Strauss at Every Mother Counts, I want to take a moment to acknowledge that while this series is focused on the role of community-based doulas and perinatal community health workers as a strategy to address the alarming rates of maternal mortality and morbidity, improvements will only be achieved through a multi-pronged approach. What do I mean by that? A multi-pronged approach means that there are many elements that are required to transform the maternity care system in the US in order to achieve birth equity. As we complete the learning series together and consider how to implement these models in our own communities, it'll be important to avoid the temptation of placing the burden of addressing all maternal health inequities solely on the shoulders of doulas and perinatal community health workers. They alone cannot solve this crisis. Access and coverage to doula and perinatal community health worker services in Medicaid is just one element of a multi-pronged approach that is needed to support system-wide transformation. For instance, we encourage you to explore our midwifery portfolio of work as another example of the multi-pronged approach. Now, it is my pleasure to introduce my colleague and partner in the learning series, Nan Strauss, the Managing Director of Policy, Advocacy, and Grant Making for Every Mother Counts, who will serve as today's moderator. Nan, thank you for your partnership and for serving as our moderator.
Thank you so much, Jennifer, for the warm welcome and for your vision and leadership bringing this learning series to life. None of us would be here without you. Every Mother Counts is a nonprofit organization working to achieve quality, respectful, and equitable maternity care for all by investing in community-driven programs in the US and globally, by working with partners and thought leaders to increase awareness, mobilizing communities to take action, and fostering systems change through transformative initiatives. We ground our work in a human rights framework, and we put mothers and birthing people at the center of the equation. Increasing access to high-value, evidence-based, community-driven models of care is central to all of our work. To kick off today's session, I'll give a brief overview of the series, its purpose, structure, and overarching themes. The learning series addresses ways to advance birth equity for Medicaid-enrolled individuals, the impact of racism and social determinants of health, and especially how early and robust community engagement in program design and implementation is essential to the success of any Medicaid perinatal support initiative. The series is going to outline pathways to expand access and ultimately provide a roadmap to explore the integration of community-based perinatal support services into Medicaid. Throughout the series, guests from different stakeholder groups will address how to work hand in hand with community-based partners toward equitable, effective Medicaid coverage of perinatal support. We look forward to building connections among organizations and individuals in the same states to foster collaboration and information sharing. And while we'll be speaking about both community-based doulas and perinatal community health workers, we want to emphasize the importance of really keeping the focus more on the services offered, the expertise, the core competencies, and the underlying approaches of a program or model, regardless of the term that's being used, because titles aren't standardized across the workforce. So you can have two programs. One is using the term perinatal community health workers, the other calling themselves community-based doulas, but they may have very, very similar services, models, training, values, and approaches. And by contrast, you might find two programs both identifying as community-based doula models, but that operate very, very differently. So by focusing on the specific program elements and how programs work in their communities, we hope to keep the emphasis on what really makes them so valuable. And that is the dignified and respectful care that they provide, the trust that they build in the communities they support, and the comprehensive approach they take to meeting people's complex needs in a way that is also individualized. We know there's no single solution for Medicaid coverage of community-based perinatal support. Different communities have different needs, service gaps, and also strengths and resources. And we know each state has its own systems, regulations, and requirements. So by sharing successful practices and perspectives from diverse stakeholders, we really hope to offer a menu of options that can help inform the design and implementation of perinatal support programs in your communities and states. If there's one key takeaway, it's that success will depend on building strong, robust relationships where community-based partners with experience offering doula and perinatal support are thoroughly integrated into the process at all stages of designing and implementing initiatives and keeping their voices, wisdom, and experience at the forefront. So as we begin session one, I'm honored to welcome a really wonderful group of guest speakers, Dr. Julie Santiago, Ebere Apareke, and Jenny Joseph, to examine the evidence around and impact of community-based doulas and perinatal community health workers to help us achieve our learning objectives. We've placed a link to all speakers' bios in the chat, so you can check those out at any time. So today, our first two speakers are both from Boston Medical Center. Dr. Julie Santiago is an assistant professor at the Boston University School of Medicine and certified nurse midwife practicing at Boston Medical Center, New England's largest safety net hospital. She's the principal investigator for the Best Beginnings for Babies study, examining outcomes of the Birth Sisters Doula program. Ebere Apareke is the program coordinator for the Birth Sisters program at Boston Medical Center. She became a birth doula 8 years ago while pursuing her undergraduate degree at the University of Michigan in Women's Studies, and she graduated with a master's in public health at Boston University in maternal child health in 2020. She's since engaged community-based strategies and advocacy efforts for health promotion and equity. We're thrilled to have you with us, and I'll turn it over to you, Julie and Ebere.
Thank you so much. Good afternoon to all. We're grateful to IMI and Every Mother Counts for the opportunity to open this important learning series. I'm going to start with a brief overview of our maternity care system and where doulas can improve care. Ebere Apareke will then discuss different models of community doula support, and we'll finish with an overview of the evidence for community doulas. Next slide, please. As many of you know, the United States has a very costly healthcare system. This is particularly notable in maternity care, as childbirth is the most common cause of hospitalization. Additionally, 40% of all maternity care is funded by Medicaid nationally. Amongst high-income countries globally, we have the highest cost of maternity care. Next slide, please. Despite high spending, we have suboptimal outcomes for both mothers and infants and large inequities in outcomes by race. Disparities for Black as well as Native American birthing people incorporates mortality, but this is just the tip of the iceberg, underneath which lies a glacier of severe maternal morbidity. It's also important to talk about other health outcomes, such as breastfeeding and postpartum depression, which influence the long-term health of both the birthing person and the child. And the experience of discrimination in maternity care, which contributes to the daily weathering and stress experienced by birthing people of color in the very institutions that paradoxically intend to promote health and well-being. Next slide, please. We can understand the range of maternity care interventions that are needed for healthy and more equitable outcomes by using this evidence-informed framework for maternity care published in The Lancet several years ago. In the United States, our care is heavily focused in the pink boxes in the upper right corner of the figure. While medical interventions are certainly a critical component of safe maternity care, we will concentrate our need in this area if we ignore the preventive care processes and person-centered philosophies that contribute to health and well-being. You can see here where gaps exist in the US healthcare system and are best filled by doulas and midwives. Doulas can provide peer education and health promotion, noted in the upper left-hand green box. Additionally, in the purple rectangle, we see the need to integrate services across communities and facilities. And in the blue block box, the need for community knowledge, respect, and individualized care. In many communities, doulas are uniquely positioned to provide this care. Next slide. To understand how any intervention, including community doulas, can reduce maternal health disparities, we need to understand that the causes of these disparities occur on many levels. I make this point because doulas are not a panacea to all maternal health inequities, as was mentioned earlier. Societal efforts must target all levels to effect change. The areas in black ink are important drivers of maternal health inequities and are not impactable by doulas. The blue ink highlights where a doula might make a difference, including navigation of fragmented health and community-based social services, providing culturally and racially congruent social support to buffer the stressors impacting birthing people of color, and encouraging positive health behaviors. I highlight bias in red because a doula with a similar lived experience as the client may create a sense of safety for them, but cannot change the structural or interpersonal biases within the healthcare system, and may even be harmed by these forces. This is the job of those of us with the power and the privilege to do so. Next slide, and I will pass it on to Barry.
Thank you, Julie. So I'm just going to provide a little bit of a historical context and landscape around doula work. And I'll start by saying that it's almost redundant to say community doula because historically for centuries, doulas have always been embedded in community. These were the grandmothers and aunties and elders who stepped in to form a web of support for birthing people in their community, just as they had seen done to others and for themselves. During the 20th century medicalization of birth, we see there was a violent and concerted strategies to suppress and stigmatize community birth practices and to instead instate an approach that prioritized and profited the largely white male obstetric field at the time. And so doulas really step into this work to reclaim a lot of these birth practices and traditions and to see birth and approach birth as a normal physiologic process that affects not just the birthing person, but that ripples out into the communities that they are a part of. Next slide, please. And so what is a community doula? We could define a community doula as a person who practices across the spectrum of the perinatal period, so including labor and birth, but also providing prenatal and postpartum support, and a really critical piece of helping a birthing person or pregnant person navigate the healthcare system, providing peer education to really address the social determinants of health. So thinking beyond what happens when the birthing person comes into labor and really thinking fully and holistically about all of the factors that impact their health. They're often community members who share that lived experience, share identities, and have a cultural congruence with the client, which provides a trusting environment and a trusting space for the client to feel safe with the people they're bringing into their birthing space. And they operate through a reproductive framework, a reproductive justice framework, in that they really think about racism and other systems and forces of oppression that are strong health determinants. Next slide, please. So there's a diversity of scopes and settings that community doulas can work in. So as I mentioned, they can work through the birth, postpartum period, as well as just the full spectrum approach. They can work in birth centers, community organizations, hospital systems, or embedded in other social services. Diversity of employment models. So there's volunteer on call models, private model in which the doula would create their own letter or list of agreements and policies and practices and provide and create their own pay structure, as well as a hospital-based model in which the hospital is the employer of the doula, and the doula works underneath within the hospital system. But really with the single purpose of building a trusting relationship with the birthing person, to be right by the birthing person's side, to prioritize and center their needs and support them in their birthing journeys. Next slide, please. And so as we're thinking about equitable strategies to support doulas and to really center birthing people, a birth justice framework reminds us that it's critical to challenge the forces. And by that, I mean people, the policies, the drivers and motivators that are traumatizing birthing people and their families and that are exacerbating poor outcomes. I'm going to pass it back to Julie to talk a little bit about the evidence for doula support.
Great, thank you. Next slide, please. So there is a wealth of studies on how doula support impacts outcomes. A Cochrane meta-analysis of 26 randomized trials, including 15,000 participants, both in the United States and globally, showed labor support by a doula, excuse me, or similar peer reduces cesarean births and increases breastfeeding. Similarly, a meta-synthesis of qualitative studies of community doula support shows greater satisfaction with childbirth, including a notable outcome of more sense of self-worth following childbirth. These qualitative studies also highlight a better sense of trust and social connectedness, as well as how cultural congruence is valued by doula clients. One study explored doula-specific communication strategies and found a unique approach to person-centered support, including techniques such as mirroring or reflecting back, acceptance of the client's feelings and preferences, reinforcing positive thoughts the client may be having and reframing negative ones, and debriefing. I point this out because it provides insight into how community doulas achieve outcomes such as an increased sense of trust, connectedness, and self-worth. Studies of doulas also consistently show an increase in breastfeeding initiation and exclusivity, and healthier parenting behaviors, such as delayed introduction of solid foods, interactive play and reading, as well as the more consistent use of car seats and putting the infant to sleep on the back. For this audience, I point out that there have been 4 costing studies of community doulas, 3 of which are modeling studies, and 1 of which is a return on investment analysis based on trial data. They show a consistent reduction in healthcare spending in the range of $1,000 per parent-infant couplet. Next slide, please. I'd like to highlight a recent article published in the Lancet's eClinical Medicine. The authors gathered doula data in states in which Medicaid reimburses under NPI numbers, California, Florida, and an unnamed northeastern state. Compare Medicaid births with a doula, propensity score matched with other Medicaid births. They show lower rates of cesarean birth and less postpartum depression among those who received doula support. The strongest effect was found for those who had a midwife on the clinical team, regardless of the timing of doula care initiation. And thinking back to the earlier slide on the evidence-informed maternity care framework, this study highlights how a workforce motivated by and trained for person-centered, community-involved, preventive maternity care can maximize optimal outcomes. Next slide, please. I'd like to end by noting some studies that describe key considerations for implementing community doula workforce development strategies. First, we must acknowledge that systemic racism is the cause of racial health disparities. If we don't, we risk creating systems that perpetuate inequities and creating unsustainable workforce systems. To avoid this, we must include communities and doulas of color in the planning, implementation, and evaluation of doula-related policies and practices. This information comes out of 2 studies, 2 qualitative studies interviewing stakeholders in community doula programs. Additionally, as with all healthcare system changes, all stakeholders must be educated about a new intervention. This includes shared understanding of the role and scope of doula work, as well as respectful clinician-doula communication practices. And lastly, but critically, models of doula employment must be sustainable. In this age of healthcare worker burnout, it's crucial to understand the physical and emotional challenges of community doula work for those from often low-income communities. They are on call day and night and accompany the birthing person throughout the often long hours of labor. They also share lived experiences, which makes them both effective and vulnerable to emotional burnout. Equitable and sustainable reimbursement rates, options for sharing on-call work, and support resources for processing the emotional stress of caring for those who may have socially or medically traumatic experiences. Lastly, I want to point out that we are at a key inflection point in our work to improve maternal and infant health in our country, and community doulas are an important aspect of moving towards these goals. Thank you. I will pass it back to Nan.
Right. Thank you so much, Dr. Matal Santiago and Abere Opereke, for your thoughtful and the very thorough presentation, for grounding us in the issues that we're going to be addressing really over the coming months. We are inviting all attendees to submit your questions throughout the session using the Q&A feature. And also, I just want to remind you that slides and the recording will be shared in the post-session materials after the session. Thank you. So next, it is my great pleasure to introduce Jenny Joseph, a British-trained midwife who fights to ensure that every person has their healthiest possible pregnancy, birth, and postpartum experience with dignity and support. Jenny created the JJ Way, an evidence-based maternity care model delivering readily accessible, patient-centered, culturally congruent care to women in areas that she terms maternotoxic zones. Jenny is the founder and president of Common Sense Childbirth, Inc., which operates a perinatal training division, a clinical division, a national midwifery school, and the National Perinatal Task Force, which is a grassroots organization whose mission is the elimination of racial disparities in maternal child health in the U.S. She serves on the Advisory Council for the Congressional Black Maternal Health Caucus, is a fellow of the Aspen Institute, and has recently been recognized as a Time Woman of the Year in 2022 for her incredible work promoting perinatal equity. I will also say that Jenny Joseph has been a tremendous mentor to me for the last 15 years, and someone from whom I have learned a tremendous amount, and I'm very grateful to on many fronts for all that you've contributed to this field. So very happy to have you here today. Welcome, Jenny.
Thank you, Nan. Thank you for that very kind introduction. And yes, 15 years, wow. And thank you, IMI and Every Mother Counts, for having this happen. I am really glad and honored to be here because this has been something very dear to my heart. This is my 40th year in midwifery. I was trained in England, in London, in a very busy hospital, and emigrated to the United States in 1989 without realizing that I couldn't just up and be a midwife, and have had a journey ever since then, actually becoming a doula because I could do that more readily than I could midwifery before I was able to finally become a licensed midwife in Florida in the early 1990s. I founded my organization, Common Sense Childbirth, because I couldn't find the common sense in the way maternity care was being delivered, not only in the state that I was in, but on a national level. Next slide, please. So we put our byline as every person, every time, because we were looking for equity. And so it's all about the big belly for us. Like, we are always excited when we see a pregnant person with that belly full term. One of the biggest things that have been impacting health outcomes, morbidity and mortality for both mothers and babies is prematurity. So when I see a mother term, I know that she has made that happen. They have brought that pregnancy all the way to full development. And that means likely on the other side of that, a healthy birth outcome and a very healthy postpartum. So we have worked as midwives and doulas to get to that point. And we've been very successful, and I want to share a little bit about that today. But as I'm speaking, I also want to invite any members of the audience to just relate to this work from a personal perspective, if you can. Because as Dr. Moore said, you know, if you love someone, there's such a difference in how you think about and how you work to support and to advocate and stand for that loved one in having the best and the best outcome they could possibly have as far as pregnancy and birth. And so let's go on. So next slide, please. I have 4 branches of my work at the Common Sense Childbirth. We're a nonprofit organization, and we provide care and services through 4 branches. First one is our clinical branch, where we have what we call the Easy Access Clinics. These are outpatient prenatal and postpartum care and women's health clinics. And we have birthing centers where we provide freestanding birthing center, community-based birth options for folk who are low risk and healthy, who would prefer to have a natural experience, a water birth, to have the care with midwifery care being the mode of delivery of care, and to have their own options and wishes respected and honored. The other branches include the midwifery school, and I'm proud to say that we are the first, and as far as we know, the only midwifery school that is privately owned, that is owned by and run by a Black woman, myself, in the United States at this time. And we are training community midwives to provide community-based care. We have another branch, which we call the Common Sense Childbirth Institute. This is our organizational department that works on training perinatal health workers. This is where we do the workforce development work. We train doulas, perinatal community health workers, lactation educators, and childbirth educators to provide, again, community-based work using the approach from meeting people where they are and providing services wherever they need them. So that includes all of the perinatal, prenatal care, delivery care, postpartum care, interconceptional care, and generalized community support for being empowered in taking care of yourself. And then the final branch is what we call the National Perinatal Task Force. This is our movement building arm, where we take on the responsibility on a national level to seek out, identify, recognize, and engage with other providers who are on the ground, on the front lines, most of the time invisible, barely recognized, barely supported, and often not engaged and invited into collaborative teams, yet they are the ones who are getting the work done. They are the ones reaching out to community members. They're standing in those gaps, and they are doing that because they feel compelled, because they feel moved, because they feel that they must be part of this revolution to transform what we have in the United States as what we consider maternity care right now. The 4 tenets of my models, regardless of which branch we're talking about, remain the same. We want to make sure there's access, unimpeded access, straight to the point access, so that the access leads to firm connections and collaborations from the trustful place, from the respectful place, from an equitable place. Connections that have meat, that are going to be solid and remain in place throughout the experience so that mothers, families, community thrives. Once we have connections where people trust and respect each other, knowledge can be exchanged, and only then can knowledge be exchanged. You can't teach or expect someone to listen and believe what you're saying if they don't trust you. And vice versa. They won't disclose or share information that's necessary to be shared if they don't feel safe doing that. So when you have these others, access, connections, and knowledge together and in that order, you'll always end up with empowerment. So in our work, we've made sure to, again, make sure every person, every time, gets taken care of, has equitable access to care, is connected and supported while they are in our care, share knowledge and learn what they need to learn to be safe and healthy, and are empowered to do so. So in the terms of the clinic, for example, and I've been a Medicaid provider since I've been a licensed provider in the state of Florida. And I made it my business to be a Medicaid provider because I wanted to reach the people who needed the care most. And so access became a real issue because if they could get on Medicaid themselves, they couldn't often find the providers to provide this type of care. Or vice versa, if I couldn't get access to becoming a provider, I couldn't accept their Medicaid And I had to make sure to find ways, whether it was to switch, reassess, do uncompensated care, but we always made sure that we had that access as job one. Next slide, please. So let me just stop a little bit here and talk about midwifery training, even though we are focused on doulas and perinatal community health workers. There is a dearth of opportunity for employment for doulas and community health workers if they are not in private practice, because the system as it stands has not yet embraced that fully. So it's midwifery as an access point for doulas and community health workers to do their work. And it's also midwifery as an access point to building out community practices so there are greater access points. So we have this continuum, this cycle where if we don't realize how to join the intersectional work that is necessary and practically join it in terms of operationalize that intersectional work, we'll never kind of break into making these changes. So we know the community midwives are the key towards getting community-based practices and access points available to communities, particularly of need. Rural communities, urban communities, communities where providers are not plentiful and open to take in every person, especially low income or Medicaid insured folk. So we are training midwives to build out that workforce, and in tandem, training doulas and community health workers to support and service the midwifery practices, as well as to be the glue that moves through all the other types of disciplines, whether it's hospital institutions, whether it's private OB practices, health departments, community clinics. So we are training midwives who are bound to work in community practices outside of hospitals, but also to complement those midwives that work inside of hospitals and the OBs as well. Next slide, please. We have been training since the early 2000s. When we began our work, doula training was pretty much, in people that were doing doula training in those days were, typically more white, middle class. We're looking at doing birth doula work specifically, and we knew that there was a need to broaden the scope of a doula, broaden the scope of the perinatal community health workers. And so our trainings have always been and will continue to be specifically incorporating social determinants of health, understanding from a racial and the class disparities that are also responsible for these poor outcomes. And in diversifying the profession, we create a pipeline as well to medical, so that we know that people who are in this kind of work are going to likely keep moving up the career path, whether they go into the clinical side, whether they go into the social work side, whether they go into the public health side. But this is a pathway. People begin at that entry level on the ground in the community, doing either doula work or community health work. We've had terrible trouble having our credentialing accepted just because of the diverse and many different trainings, different pathways and competencies as well of doulas and community health workers. But we must get to the point where we are looking at ways to credential these folk so that they can be reimbursed, because much of the work, as I've said earlier, is not even recognized, is not even accounted for, but yet is essential to the improvement of our communities at large. So next slide, please. Let me talk a little bit here then about the National Perinatal Task Force. What we realized was that the folk who are doing the work that we do, including the midwives, are feeling very isolated, very alone, are struggling. And burnout is absolutely a problem and an issue. And it's heartbreaking when you train doulas and within a year to 2 years, they have to change that profession because they cannot sustain it, not just from a financial place, but from a support place, from their family needs and their personal needs, their inability to go day in and day out, overnight, being on call, trying to hold 2nd and 3 jobs to manage to be able to keep offering these services in their community. What we've done with the National Perinatal Task Force is create a network of support, recognizing and centering the providers, as opposed to, in this case, centering the mother-baby or the mother-baby family. When we center the perinatal health workers, let them know that we're there with them, let them understand that we see the problems they're enduring, that they are acknowledged. The support is helpful in everybody becoming more able to work in tandem, to work as a team, to lean on each other for best practices. We have essentially established what we are considering a national community of practice. And inside of that, we do that by creating trainings and workshops where we do what we call collective care for the community health worker providers, collective leadership. And we also do specific work in terms of advocacy and community organizing in order to strengthen this workforce and, again, to bring sustainability. This picture here is one of the clinics that we run in Orlando, where we had a community baby shower, and the community health workers, the doulas, the midwives, everybody came together to create a space where we could have a lot of fun. We had food, we had learning, but we felt that in offering these groups and these meetings, these baby showers, we were able to sort of pull together and to really tighten and strengthen how we as providers relate to our clients, but how our clients also see us in terms of strength, in terms of power. We are our own best resource. What we're asking is for that recognition, in embracing the work that we do and incorporating it into the bigger structural work so that we can. When we look at the types of policies and the types of support that we need, it is around recognizing the infrastructure that needs to be built to support community doulas and community providers. Next slide, please. So here are some of the health workers that we've worked with over the years. We've made it our business to highlight and to stand for safety, quality, and equity inside of the workforce, the same way that we have for the mother-baby family community. On the far left is June. June is a community health worker. She was also the person holding that sign at the beginning of my slides. June has worked with us over 10 years. She came to me just one day as a volunteer. She lost a child due to a rare genetic disease, and she felt compelled to support her community. And from there, we trained June into doing doula work. She's an educator. She's a resource manager. She's everybody's grandma. She's just always there. You can count on June. Megan, who's standing next to June, Megan is now a nurse practitioner. She started with us as a birth assistant in the birthing center at age of 18 and went straight through from there on to nursing. She's now a nurse practitioner, like I say. She's doing amazing work. And this just happened from her coming through as being interested in birth and wanting to find a pathway. Katrina, with the pink stethoscope around her neck, she's worked with our program for 17 years. And she really is the epitome of the example of what's possible with community pipeline folk. She is now managing the clinical division. And Alexis, likewise, came to me as a medical assistant and worked almost 10 years as well. She's moved on to work for an OB practice now. So we know that there's value in supporting people who want to come into this work at this level, and that they need to have the supports that are necessary. Last slide here. So we're looking at this angle. Next slide, please. We're looking at this angle from a perspective of how do you get this done? How do you do it in practical ways? What steps are needed? What policies are needed to support? But when you do it and you take on that justice aspect of it as well, because it's unconscionable that we, as the most developed country in the entire world, should have such horrendous and wretched outcomes for people when there is absolutely No need, because you can see in this picture, these are more mothers from the clinic. This is a postpartum group. Look at the rolls of thigh on these babies' thighs. These are breastfed babies. These are happy mamas. You don't see pictures like this as a matter of course. This should be how every postpartum group looks. This should be how every postpartum mother looks. This is how every baby should be looking. There is no excuse for us to continue to say we don't know how to fix this problem. Yes, we do. And I'm here to say that doulas, childbirth educators, lactation educators, community health workers, and midwives can solve this problem. We simply need to figure out how to support them, and let's get going. So thank you for having me today.
Thank you, Jenny, so much. Thank you for that inspiration, which you never fail to provide. That was a beautiful presentation. And I think really brings us back to the reason that we're all here, and that is the mamas and the babies, the birthing people, the families. Thank you for reminding us and keeping us centered on that vision. Pardon me. So thank you, Jenny, Abere, and Julie, all of you, for giving such important and insightful reflections and resources as a kickoff to the learning series that we will carry with us throughout the following months. Right now, we want to open it up to questions from the learning series participants. So please continue to submit your questions using the question and answer feature. Dr. Jennifer Moore is going to provide the first question.
Great. Thank you, Nan. Thank you to our speakers. Jenny, wow, you are inspiration for all of us and a model to follow in your leadership. And I have lots of questions for everyone, but I'm going to start with our first set of speakers, Dr. Matos Santiago and Abere. You heard Jenny talk about equitable payment for services. And given the impact of doulas and perinatal community health workers on their outcomes, and the importance, as Jenny had mentioned, to allow this to be a profession, to really serve the community. As you think about the models, the policy and programs that should be considered for the Medicaid program as they think about implementing access and coverage to doulas as part of their programs, from your perspective, what are some of the key considerations that folks should be thinking about?
Thank you. Excuse me for that question, Jennifer. I, as a doula myself, and just thinking about, the experiences I've had and I've shared with other doulas, I think about, as it's been reflected a number of times in our conversation here, where we're putting the onus and responsibility for eradicating and addressing embedded systems and forces of oppression. If we are saying that doulas are so impactful in centering the autonomy of birthing people, but we're not creating any space or shifting any of the norms and practices that are traumatizing birthing people, there's a natural clash that happens when we're seeking to pull more doulas into spaces. So you can have the doula who is educated, connected to community resources, who is there to provide services and to show up for a patient. But if they're walking into a system and walking through spaces that do not see and value their work, and that are also working against the care that they're providing, then we're going to have the same outcomes and a traumatized doula. So really coupling our strategies for reimbursement with necessary strategies around accountability, really stressing that the system, if we have to create system changes and not just pulling in other people and other care workers who can, provide aspects of care that are not currently present. I'd like to see that more attention being placed in that side and really thinking about how do we shift our whole system and all of the other areas and avenues that, work needs to happen.
Thanks, Abere.
Yeah, I would agree with what Abere is saying. And, I think it's important not to think that it's just a provider reimbursement that gets distributed, that it really does need to have all of these other levels of accountability and, thoughtful implementation. And I also think it's important to acknowledge that different doula models will work differently in different places. So there's not one strategy, but there are some key things that every doula program or individual doula needs, which is support around training, and that should not provide more barriers to that work. Support, we have the same experience with our hospital-based doula program that Jenny was describing around people feeling isolated and getting burned out because it's hard work. And so figuring out how to create that sustainable, both financial and sort of professional support networks and models. So I think it's important to think about the big picture and how to make it successful.
Great. Thank you for that. Thank you both. Jenny, I'm going to go to you now. And before I came to this session, I was rereading your feature as Time Magazine Woman of the Year. And I hope everyone takes a moment to read this, because the magnitude of your vision and impact is tremendous. And you truly are an inspiration. One of the things that I noticed in the write-up is the word alternative. I've been using this as the term alternative to respond to doulas, perinatal community health workers, midwives. But I think you and I both would agree that this is not alternative. It's actually the standard and the original approach to maternity care in every country around the world. As you think about your vision going forward and the need to build community-based workforce, which we saw a huge deficit during the pandemic and how critical they were, what do you see as the next steps? Thinking about healthcare deserts, maternity care deserts, where do we go? How do we build this workforce? What is needed?
We need to normalize. That's it. We need to recognize that these are people who are doing the same work that people have done for millennia, right? Mm-hmm. And enable and support them, empower them to do that work without impediment. So what we're looking at is really what I call the maternotoxic zones, wherever that shows up, which is pretty well everywhere, that they are in place, established, and standardized. Our maternity care system needs to be a standardized system, and with the equity meaning that wherever you are, however you are, whatever you need, that there's one consistent component that can be applied to it. Respectful care, dignified care. Just treating people with humanity is the leveling factor and is accessible to us right now. So we can support and empower the providers of that care by being able to put the infrastructure in place for them to be able to do what they need to do. They already know what to do. They just need the support. So if we normalize that this is how it is when you have a maternity care system that works, then we will get to that goal, I think, a whole lot quicker.
Thank you for that. And I want to build off of that a little bit. I was looking in the Q&A, and please, everyone, continue to submit your questions. We have several obstetrician gynecologists in the audience today who are essentially all asking the same question. What can they do to support this model of care? What is their role? And I'm just wondering if maybe one of our panelists want to offer some suggestions.
I would love to. Just really quickly, just understanding that doulas are not anathema to healthy outcomes, that helping yourselves and your colleagues to understand that the antagonism, the territorialism, the negativity that sometimes shows up where doulas and obstetricians are working together. If we look at that from a perspective of actually they're complementary, and to help promote it from that angle, that would so help everybody get where they're going. Where physicians support doulas, parents, they thrive. Where they don't, the obstacles remain, and we still don't see those changes that we're looking for. It's about just really understanding what we're doing and why we're doing it, and collaborating together.
Great, thank you for that. We're running out of time. I wish that this was a half-day event, but I do have one question. And we're all coming here today to be inspired to take action, inspired to learn how to implement these models of care with a commitment to addressing birth equity across the US. I'd like for each of our panelists or speakers to give us one recommendation. You've shared a lot about evidence, you talked about models, you talked about opportunities, but what's one recommendation that you would give to Medicaid health plans, state Medicaid agencies, federal government, other stakeholders in this space who are considering implementing Medicaid coverage for doulas and perinatal community health workers? And I'm going to start with Dr. Julie Matos-Santiago. We'll go in order of the speakers. Real quick, one recommendation.
I think including communities and doulas of color in the development of whatever system that particular agency is working on. That's critical.
Thanks. Barry?
I would add to create a system that's least burdensome to the doula. I think oftentimes we create structures of professionalization and certification that seek to have the doula prove their worth, prove their value, prove their legitimacy to a system. And in turn, that creates more burden for them in accessing the resources and accessing the support that they need. So creating structures that are least burdensome and allow them to still operate autonomously and operate most closely to the birthing person.
Great, Jenny.
Taking responsibility that it is up to us to operationalize these systems. We need to be the ones to support and build the infrastructure that will maintain and hold for sustainability.
Nan, as the moderator, do you have a recommendation that you want to share to the group?
I do. I just have one thought that occurs to me based on a lot of the questions in the Q&A, as well as what everyone else has added, which is so thoughtful, which is we need to really make sure that we're not thinking of doulas or perinatal community health workers or other kinds of perinatal support folks as individuals, just billing as little individuals out there with their little independent practice. That does not work in this situation because of burnout issues, because of the referrals that have to be made, because of support structures and not making people feel isolated, but making them feel supported in what is a very challenging job. So one of the things that I've seen the most needed, but not yet really fully worked out is how do we incorporate not just doulas and perinatal community health workers, but community-based organizations that can serve as that hub, that learning center, that provide that mentorship, that peer support, the professional development, and many of the aspects that Jenny talked about her program and work providing for some of the folks that you saw in that last slide on her staff. It's essential to have organizations holding those roles. Thanks so much.
Thank you for that. You know, having the infrastructure in place is really critical, and appreciate that wrap up there, Nan. So thank you to our speakers. This was a great session, great way to kick off our doula and perinatal community health worker learning series. Thank you to the participants. We received way more questions than we could possibly get to, and I was trying to synthesize them as fast as I possibly could. Because there's 1,000 of you here today, I just want to note that as Yanti had mentioned at the beginning, we're going to send the questions, every single question that came in, to our speakers today, and Nan is our moderator, and they're going to compile their responses, and we will send out an FAQ document afterwards as part of the post-session materials. So your questions will get answered, and that is true for all future sessions too. So continue to submit those questions. Now I'm going to hand it over to Yanti Wheeler, who's going to close us out for today's session.
Thank you. At this time, everyone should have received an email with the link to complete today's brief 3-minute survey, feedback survey. If you did not receive the email, you can contact me. My email is listed on the slide. For your convenience, we also will share the link for the survey in the chat box so you can begin to complete the survey as we wrap up. As a reminder, completion of this evaluation is required as part of the participation in the learning series, and we will be using this feedback and incorporating it into future sessions. including planning the topics for session 7 and 8. As we saw in the question and answer section, people were asking about the materials. All materials from today's session, which includes the slides and the recording, we made available to you on the IMI website about 2 weeks after the presentation date. So be on the lookout for that. And also will be sent in a post-session email 2 weeks after. Session 2 of the Doulas and Perinatal Community Health Workers and Medicaid Learning Series is Program and Training Models for Community-Based Perinatal Support, and it will be held on Thursday, January 5th at 3 p.m. Eastern Time. Keep an eye out for the pre-session email with the agenda and the required pre-session activities. And if you haven't already, please remember to add Jennifer Moore to your email contact list to ensure that the series emails are not sent to your spam. Her email is also posted on the slide. So we want to thank you again for your participation. We look forward to seeing you in the new year at session 2 on January 5th. Thank you so much.